My name is David Kenigsberg. I'm a private practitioner in South Florida. I've been there since 2007, and I'm going to give you my perspective on Barostim therapy and why I use it for my patients. So when I was asked to give this talk kindly by Paul, I thought about why is it that I care so much about treating heart failure patients. And what came to mind is a song written by Elvis Presley, which goes, "Walk a mile in my shoes." And as physicians, we sit on the opposite side of the table or looking at a patient in a gurney, and we don't always relate to where they're at. But if you look at a heart failure patient and you talk to them and you see where they're at, I don't know that they care so much about mortality, but they definitely care about how they feel. And they definitely are looking to you, looking in your eyes, and asking you to help them to feel better. And that's why I think Barostim therapy, for me, has made such an impression. So when it comes to all the randomized controlled trials looking at heart failure hospitalizations and mortality benefit and all the CRT data that we have, CRT is great. And I love putting in BiV devices. I've put many in the past 15 years in practice, and patients do well. But not every patient meets criteria for BiV pacing. And we used to think we could put this in patients with QRSs greater than 120, but actually in males we know that they do better if their QRSs are greater than 150. So aside from CRT therapy, what else do we have to offer patients? And what do we have to offer these patients that don't have wide QRSs? For years, cardiologists would tell me, you know what, their QRS is narrow, but BiVs work so well, just throw it in. And we know that if we do that, we can cause dyssynchrony and make people actually feel worse. We may even increase their mortality. So that's not an adequate option. So in this slide, there's basically two devices currently FDA approved and allowed for patients who have reduced ejection fractions and have heart failure symptoms in the presence of a narrow QRS and who are on guideline-directed medical therapy. And what I'd like to point out in this slide is that Barostim takes you from less than 35% EF all the way down to the very low EFs, where you have two myocytes held together by a spirochete waiting for an antibiotic. So here, these patients can benefit from some other therapy, and we'll go through why the differences exist. So I've actually implanted quite a few optimizer devices. I think it's an excellent therapy in certain patients, and I've gone through and implanted a number of Barostim devices. A little bit different than most electrophysiologists maybe is for every one of these devices, I've been actively involved in the procedure, the entire procedure, and maybe for some of them, I've done more than just put in the generator. So in these patients with ejection fractions of 25 to 35%, if you look at the two trials, there's definitely an improvement in exercise capacity, an improvement in quality of life, an improvement in New York Heart Association class. And there is some data for improvement in peak VO2. Now, Dr. Singh adequately went through all the evidence, and I'm not going to do that again. But when I look at a patient in the eye and I have heart failure in front of me, what do I decide and why do I decide which device to offer these patients? As I said, there are two options. So if the EF is less than 35% and they have New York Heart Association class 3 or class 2 or 3, and let's be honest, there's a very fine line between class 2 or class 3. That could be the bag of chips that the person ate last week or the last few days. But the Barostim device is distinct in the sense that there are no leads inside the heart, which is very important. As someone who does extractions and has to pull leads out that are now been in for 20, 30 years, I think it's important to consider the morbidity and potential mortality associated with having additional leads inside the heart. And most of these patients, especially all the ones with EFs less than 35%, have defibrillators. So they have at least one lead, if not three, inside the heart. In the impulse dynamics device, this device can be easily implanted by an electrophysiologist who can put a lead on the septum. In the Barostim device, this device is done with a cut down over the carotid and the lead tunneled, and I'll show a slide in a minute, to a generator, which is usually in my case, the right delta pectoral groove region or in the mid-chest, because on the left side exists the defibrillator. I do think that this device, as well as the lead, are amenable to an electrophysiologist implanting by themselves, and potentially there will be a way to do that with minimally invasive techniques in the future. The battery is a 6-year battery with no recharging needed for the HFrEF device. The impulse dynamics device is a rechargeable battery. I will tell you that when I was a fellow at MCV in 2005, I did put an impulse dynamics in at that time. At that time, the size of the device was the size of that little device they gave to you when you went to the Cheesecake Factory and were waiting for your table. It's gotten considerably smaller to this day. So if you look at these chest x-rays in front of you, as you can tell, the patient with the Barostim device has a lead inside their heart from their defibrillator with a device sitting in the left delta pectoral groove. And on the right side, they have a lead tunneled up to the neck where it's sewed down on the carotid. On the left side, the CCM device patient has multiple leads in the heart coming from both the left and the right axillary subclavian veins. So I think in our world, everything is moving towards leadless devices. Dr. Ellenbogen wrote a paper probably in 2005 or before saying that the weakest link in device therapy is the lead. And so over time, we're moving away from leads, sub-Q devices, leadless pacing, and no leads inside the vasculature with CVRX, I would say, is part of that idea. So as far as the implant technique, as I mentioned, it's a small incision in the right chest, about 2.5 centimeters, where you put the device and then tunnel the lead up to sew it onto the carotid. The procedure takes no more than 15 to 20 minutes. X-ray is not needed. Another big trend in electrophysiology to do fluoroless procedures. The patient can go home within a few hours after the procedure. I'd like to spend the last few minutes of my time, hopefully I don't go over, actually I am, talking about 3 distinct patients or patient types that I think benefit from this device therapy. So the first one is a dilated cardiomyopathy. It's a heart failure frequent flyer, as I would call her. She's a 59-year-old African-American female who keeps coming back to the hospital with heart failure admissions, class 3 symptoms, despite optimal medical therapy. She has had multiple ICD therapies due to sustained VT. She has persistent heart failure symptoms and elevated heart logic. I put a Barostim in her in July of 2022, and at the time of implant, her blood pressure was as shown. Subsequently, she lost weight, but most importantly on this slide is she has not been readmitted since that time, which is almost a year, which for this young lady is spectacular. The next patient is a patient with a post-infarct cardiomyopathy, a 78-year-old gentleman who also had multiple heart failure admissions on optimal medical therapy and underwent around the same time a Barostim implant. And as you can see, their body weight went down by 7 pounds. They have also not been readmitted. And for this gentleman, what I think is most striking is his increased stamina. This gentleman enjoys walking up hills and taking walks with his grandson. He likes to walk the golf course. He was not able to do that prior to July of 2022. And the final patient, which I think is important to mention, are CRT non-responders. Now, I don't say that term lightly. I think it's very important that we place our lead laterally, that we do everything possible to make sure there's not an apical position, that the device is appropriately programmed as far as timing with AV and VV timing. If you'd like, you could do any kind of optimization you'd like, But at the end of the day, there are a subset of patients that have appropriately placed BiVs with true left bundle branch blocks that do not respond to CRT. And this is one of those patients. He actually found me and was my first implant in May of 2022. And since this device has been put in, he has done remarkably well. He was extremely anxious, which it wasn't anxiety. It was paroxysmal nocturnal dyspnea, actually. So he stopped his anxiolytic, and he's doing very well. He's back at work full time. He's exercising. This is a true success story. So we talked about the EP toolbox. Dr. Singh just mentioned it. We obviously have CRT. We have impulse dynamics. We have CVRX. There are some other devices that I played with, like EBR. But at the end of the day, we need to do something for our patients outside of just dealing with their mortality. And believe me, these patients want you to walk a mile in their shoes. Thank you very much.